some just managing deteriorating patient and just some basic patient assessment. So I don't think we did some thunderstorm asthma last month, I reckon. And then I know before I went on leave, we went through just some basic clinical approach. So this is just a bit of a refresh for that. And then just some recognising when someone's deteriorating, what we're going to do with them. How you doing?
Hi.
So I guess what and I'm sort of basing this on ambulance, not so much hospital, because obviously ambulance is my experience, and that's where I know where we make errors and all that sort of stuff. What we do really well is assess a patient. What we don't, and we treat them and we work out what we're going to do with them and all that sort of stuff. But what we don't do very well is then reassess them. And especially when we get, we're particularly bad when we get routine transfers and we're dictated by, it's a hospital pickup, it's a non-emergency job, no non-emergency patient transport available. So we go pick up this patient, we then just do a bit of a basic handover from the hospital, and then we sort of get on board and then do another assessment, and then don't really, I guess, take too much into account because it's just a routine thing. They just need to go out for surgery or something like that. And we have ended up with quite some sick patients along the way because they haven't either properly been handed over, then not been assessed, or there's obviously not, I'm not talking about Boort, I'm talking about ambulance in general. We're generally good at the assessment, not so much the reassessment, but as we know, the reassessment is just as important. So why do we need to reassess a patient? Yeah, so find out if our treatment is actually working. So we want to know, is our treatment working, or are they getting worse, or are they staying the same? What else?
So they don't deteriorate?
Yeah, so essentially, is this patient stable? Are they getting more unstable? Do we need any more help? Obviously, we work in rural locations, so we need to recognise pretty early, do we actually need any help? Because it's going to take a long time to get here. So yes, you may have a doctor in town, you've got the ambulance volunteers in town, your nearest paramedic is probably 40 minutes away, if you're lucky, and then you've got intensive care paramedics, which are an hour, and your helicopter, which could be an hour, 2 hours, things like that. So that's why I want to recognise these things early. So this is something quite simple that we presented at our volunteer conference, and it's just essentially I don't know the quick word for it, but essentially it's just a bit of something to picture to follow each step along the sort of pathway in assessing and managing a patient. So I've got 5 words up there: assess, reassess, treat, judge, and plan. And I've got 4 boxes, but one of the boxes will accept 2 answers. What do you think the first part out of those 5 words is going to be in our patient assessment? Assess, reassess, treatment, judge, plan.
Assess?
Assess, yep, absolutely. So the first thing we want to do is assess the patient. So what sort of things do we want to know when we're assessing the patient? Let's say we won't focus on so much on the sort of the either the aged care or the sort of ward side of things. We might sort of focus on more urgent care in the fact that you may not know the history and all that sort of stuff. So what sort of things do we want to know from this patient? Patient presents to the urgent care. I need help. What do we want to know?
Start from the airway, breathing, circulation.
Yep,
ABC.
so we want to make sure they pass their ABCs. Yep. What else?
Injuries?
Yep. So, mechanism of injury. Oh, actually, sorry, I'll go back. We want to know their injuries, or essentially their nature of illness, really. So, are they presenting with an injury, or are they presenting with shortness of breath, chest pain, all that sort of stuff? Does that make sense? So you've got your injuries, and you've got generalised illness. Yep. What else?
Like the background history, start from patient. Yeah.
Yep. So the background.
Yeah.
So when you say background, what do you mean by that?
Medication history, medical history.
Yep.
Family
So we want to know
history.
about the patient themselves. So we want to know their meds, their past medical history,
The social history or
Yep.
family history.
And social. So do they live alone? Do they live with someone? What's their family history by all means? What else do you want to know?
Their their GCS?
So we want a good vital sign survey, absolutely. So what sort of things, GCS, I'm going to go with that. What's a normal GCS?
15.
15. When are we going to start getting some concern with the GCS?
Below 13.
Anything below 13 is not ideal. So, might be a bit more clearer. We'll say N for normal and we'll say, it's going to say B for bad, we'll just say T for time, potentially time critical. Cool. Alright, so we've got a normal GCS is our 15. And anything below 13 is going to be a concern. What else do we want to assess with this patient?
Vital signs. GCS.
Yep, so what else vital signs wise?
Blood sugar levels if needed. Depends on the presentation.
Yep. So we'll say, like, we don't know what's wrong with them. They're coming with an altered conscious state. So we're going to test everything, aren't we? So, what else have we got? We said BSL. What's a normal BSL?
Can be from 6 to 8.
Yep, anywhere between 4 and 8 is relatively normal. Under 2 or this number could be anywhere, but where you go your hypo, your hyper, people could be well and truly GCS 15 at a BSL of 2. They might be GCS of 3 at a BSL of 4. It's just going to be depending on different people. And obviously this is going to depend on, not every person that walks through the door is going to get a BSL straight away, but if they're coming in an altered conscious state, I've just found this guy in the car park, it's something we want to consider straight away. What else? What other vital signs are we on?
Obs.
Sorry?
Obs.
Yep, what sort of obs?
Blood pressure.
Yep, BP.
Test.
So what BP are we considering normal?
It's systolic about 90, so 120/80
Yeah.
somewhere.
So systolic and diastolic.
Yeah,
So what's the normal range for our systolic?
it's 110, 120.
Yeah, 100 to 140 is relatively normal. Now these might not be quite in line with what yours are, but they're just roundabout. And diastolic?
Happy with about 60.
60 to 80 is a relatively sort of range for a diastolic. When are we going to be concerned with blood pressure? We'll just focus on systolic predominantly.
Below 90 is a concern.
Yep.
And
Any sort of above?
about 150. Oh,
Yeah, 150 is probably going to be, getting up there to make us concerned. It's not going to be, a blood pressure of 160 is not going to make them time critical necessarily, but we'll see what else they've got going on. What else have we got? What other vital signs?
Pain.
Yep, pain. So although pain won't kill them, it's still part of our assessment. Actually, I'll put that down here. Pain assessment.
Pulse.
Pulse, yep. What's our normal pulse?
60 to 100.
60 to 100. When are we going to be concerned with pulse? At what ranges? Yep. What numbers are we talking?
10 to 100 and something.
Yep. So we might be, anything 110 or above, 110 or above, we might be concerned with. What about low side?
below 40, 50.
Yeah, so anything below 50 might be concerned. Again, this is going to be based on what they're presenting with. If they've got a blood pressure of 60 and a heart rate of 120, that's a bit of a concern right there. What else we got?
O2 set.
O2, yep. What's our normal SpO2?
95 to 100.
Yep. 90. So anywhere between 92 above is normal. So you use 94.
93, yeah.
Is 93?
Yeah.
Yep. So anything below that is going to be a little bit of a concern, depending on the patient. And what else we got?
ECG.
Yep. And what sort of things in an ECG are going to be deeply concerning? Straight away.
ECG, VT, VTVF. definitely a systole.
Yeah, so all our non-perfusing rhythms are going to be quite a concern, obviously. Our ST elevation is going to be a concern. Our bradycardias, tachycardias, that sort of stuff is also going to be a concern. What else have we got?
Respiration.
Yep. And what are we looking for in a rest break? What's normal?
It's always 60 to 80.
Is it 12 to 24?
12 to 20 is the sort of standard. ABU is I think 12 to 18, which is quite narrow. But like it's quite a, you can move either side of it pretty well. Anything below 8, that's going to be a concern. And anything above your sort of 30s, that's going to be a concern as well. GCS, BSL, BP, heart rate, SpO2, ECG, respiratory. Have we got most of them, I reckon?
Temperature.
Temperature, absolutely, yep. What's a normal temperature?
35.
35.5, is it?
35.5 to 37.5.
Yep. So ours is 36.5 to 37.5 is normal, but yours could be a little bit different, so I don't want to tell you the wrong thing. What's your temperature range for normal here?
Yeah. Currently it's about 37.5 is not good.
Yep.
Yeah,
So
there's
that's
a
right. So we'll say
correlation.
35, 36.5 to 37.5 is normal, and then anything above 37.5 or when you get down to your 34s, that's obviously going to be a bit of concern as well. All right, so I've got a few things to work out when the patient presents. We need to, one, ABC. They come in, are they talking to us, are they not? We're essentially following very simple basic primary survey, DRS, ABCD, aren't we? So no matter where you are in the clinical skill level, whether you're a Joe Blow first aider or whether you're a cardiac surgeon, we always follow DRS, ABCD. That doesn't really change. And whenever we get messed up, we always just go back to DRS, ABCD. That's what we do. So we've assessed what are they presenting with, the injuries, illness, their background information, given their medications, previous history, allergies, social status, vital signs, so we referred up there, our pain, and then obviously we want a bit of a history based on how they've come to this, don't we? So essentially a current history or chief complaint, whatever you want to call it. So I've got a bit of information to find out in that initial assessment. Cool. How long is that going to take us?
Primary, 10 minutes.
Could take 5 minutes, could take 10 minutes. If they don't pass the ABCs, then the assessment doesn't take very long because we don't go past the ABCs if we can't, fix them there. But you're right, could be about 10 minutes. So we're 10 minutes down. Patients walked in, rang the bell, we've come in, done the COVID screen. We're potentially 10 to 15 minutes into this point. What's our next one? We've used assess, what are we going to do next?
Plan.
Not quite?
Judge.
Judge. What are we judging?
The information that we've just...
Yeah, we're judging, is this patient sick or not sick? And when I say sick or not sick, I mean, are they really sick? Or have we got time to actually just sit down, let's have a look, let's go through our protocols, let's investigate further. When we talk about ECG, that's probably just going to be a 3-lead or 4-lead initially for our assessment, unless they're coming in with crushing chest pain or whatever. So this is where we judge, are they, what we say, well or unwell? What are we going to do? When somebody presents to the urgent care, they ring the bell and whatever, so say it's after hours, does one person go down, or 2 people go down? What's the process?
Urgent care.
Yep.
If it's after hours, we have an intercom system which the person can directly talk to the nurse in charge.
Yep.
And then they will do the basic COVID screening and everything through the phone itself.
Yep.
And depending on the severity, it depends, whether one person go down or not. So usually the RN goes in.
Yep.
Yeah.
So we'll say one person average, unless that sounds sick at the door. Cool. So we've determined at this point that the patient is unwell. What are we going to do?
Plan.
Yep. Before that, you are right. There's the next step. So don't worry, you've got that point. But the patient's unwell, the patient is sick, the patient is what we know is time critical.
Yeah, we need more resources.
Yeah, so what are we going to do for that?
Either contact, if we need more staff, we alert staff, the buzzers and call more.
Yep, so we've got the buzzers. Every room has a buzzer, or every clinical room has a buzzer, I assume. You've got the two buzzers, you've either got staff assist or emergency, is that correct?
In acute and emergency, we have the emergency buzzer, which has a different separate sound from other buzzers.
Okay,
But
yep.
in aged care, we only have the staff assistant.
So what's your criteria for pressing the emergency button?
If you need an emergency, depends on, you go through the doctor's ABCD, and
Yep.
if you find there is danger, if you need more assist immediately, we press the red one.
Yep.
Which is the emergency one. So
is that just for cardiac arrest, or is that for a violent patient, or when would you use the? So if you heard the emergency alarm go off in the hospital, what would you be thinking? What are your steps to take from that point?
we'll just go down and attend as soon as, so if you have a resus trolley, if you need to take that, we'll take that and run to the
Yep.
patient. Yeah.
And so the resus trolley sits in urgent care
Urgent
normally?
care, yeah.
Cool, no worries. So we need to get help, don't we? So whether that be hit the buzzer emergency, we want some more people down there, or whether that be on the phone 000 to get some more help. Now obviously our initial response being our volunteer ambulance officers are a lower clinical lower clinical set by all means, but they are a more set of hands, and especially at night, it might be the more set of hands that you need in there. So don't be afraid to call 000 early to get the ambulance rolling all the resources to you.
And even in the observation, we have the clinical review and the med criteria in purple zone and it's the orange zone. So
yeah, so your paperwork sort of tells you.
it tells you if it's
cool. So the patient's unwell, we want to get more help. However we do that, bang the emergency button, 000, or if the doctor's in town, I don't know, does the doctor come in for a job?
Yeah, if you need it. Yeah, we have afterwards emergency doctor as well if the doctor's not available.
Yep.
Yeah, so it's just on call.
Yeah, cool.
If you want, he'll come on.
But I'm saying like the patient's failed their primary survey, so there's no point doing a phone, like a telco, just to Bendigo, whoever my emergency doctor or whoever you use. Essentially, we're looking for hands, or someone that can assist hands-on in practice. So are they well or are they unwell? And that's based on our vital signs and our patient presentation. So what are some things, apart from our vital signs, that may get you thinking this patient has potential to be unwell? So when we look at vital signs and they show us exactly what's going on at this point, and so we call that actual time critical, because we know that their GCS is low, we know that they've got no blood pressure, we know their heart rate's pounding out. That tells us that this patient is actually time critical as they sit in front of us. What sort of things, being injury or illness, will make you think this person has the potential to be quite unwell or become quite unwell?
Like their age?
Yep, so why would age be an issue?
Their age would depend how well they were.
Yeah, absolutely. So it'll depend on how well their body can compensate. So if you've got someone really young or at the other extreme of age, their ability to compensate is going to be quite impaired. And that's going to then relate to why have they presented. So if you've had a 20-year-old male that's fallen off a seat and hit their head on the floor, not a big deal, probably, might knock some sense into them. What if you've got 80-year-old Nana that's done that? Probably a big concern, isn't it? You've got the potential for weakened blood vessels in the brain, they're probably on warfarin, they're probably on aspirin, all sorts of things could be going on. So that patient has the potential to deteriorate. What else?
Mobility?
Sorry?
Their mobility?
Yeah, absolutely. So how well can they ambulate? How well can they actually care for themselves in regards to when has this actually happened, and potentially what is the how well can we trust the history that's come about if they've lived on their own or something like that. So that's going to again make us think this patient has potential to go downhill quickly. What else? Think about your traumas. Think about your your significant sick patients that might present.
The mental state.
Yeah, so certainly your mental health assessment is going to be really important because that could, whether it be clinically or whether it be as part of your occupational violence or something like that, that patient can obviously change. But let's think of things like the patient presents with a long history of say COPD or something like that, or asthma. We know those patients can deteriorate quite quickly. We know from our thunderstorm asthma last month, people without asthma can deteriorate quite quickly in that sort of event. Think about our traumas. So somebody's come off, I don't know, what do they do on the water? Do they jet ski or water ski or, yeah, those patients, huge potential to actually, have a lot of injuries there considering the speed that they come off. And I don't know if anybody's ever been water skiing and you come off and that water is pretty much, feels like cement when you fall on it. Lots of injuries there. Farming accidents, vehicle accidents, all that sort of thing. So, somebody backs out of the main street and gets hit by another car at 40 k's an hour. Yeah, there's potential there. But somebody has the same accident on the 100k stretch of highway. Huge potential there, isn't there? So think about your history on what's the likelihood this patient could deteriorate, and also as part of their illness and comorbidities as well. So patient presents to you, they're a 30-year-old female with crushing chest pain. There's a potential there, but it's probably unlikely. But the 64-year-old male presents to you with crushing chest pain. That's a bit more of a concern right there. Went to a job last week with the big hay bales. They weigh about 600 kilos each. So he was getting a pile of them, 3 of them. So the fork's going to the first one and then like 2 sitting up on top. And he's lifted it up and the top one's come down straight down on top of him, smacked him in the head, knocked him out. He was 64, he had significant cervical pain, significant shoulder pain, what we thought was reduced air entry on one side, and what we were thinking is potential cervical compression fracture, all this sort of stuff. We were trying to get HEMS, it wasn't available. And he walked out with literally no injury whatsoever. He's 67 from memory. So he has the huge potential to deteriorate. So things like that, if that person presented to the urgent care right now, we'd want to, we don't really want to hold on to this patient very long, do we? Because there's potential there. So his vital signs, except his respiratory sort of, his breath sounds, we're all stable, but he has the potential to deteriorate. Motorbike rider comes up 100 k's an hour. They might be actual time, fine. Huge potential to deteriorate. Okay. I had a job last night they picked up someone from the Seymour Hospital. He'd been hit by a car on a bike 12 hours before. Didn't want to go to hospital, felt fine, all that sort of stuff. Then presented at the Seymour Hospital, and they had to get HEMS because he had no air entry on one side, significant cervical pain, GCS of 11, I think, when ambulance got there. His blood pressure was down around 80, his heart rate was 130. So those sort of things, that was 12 hours after the event. Okay, so we've got to think about what is the likelihood that patient can deteriorate. So assess, judge, well or unwell. Then what are we going to do?
Plan.
We're going to plan. Cool. What does that plan entail? How are we going to come to a plan?
Plan, prioritize.
Yeah.
Yeah?
And look like where you're going to take them.
Sorry, where are we going to?
Take the patient.
Yeah, so what are we going to do with them? But let's say they're still in urgent care at the moment. So we've essentially just assessed them, we've judged if they're sick or not sick to whether we want to get more help. Regardless of whether they're well or unwell, we're going to come with a plan, don't we? So we're going to go through our priorities. So, if we've assessed them and judged they're unwell because they've failed the primary survey, well, that's easy. ABC, ABC, ABC all the way, easy. And the sicker a patient is, the easier they get, believe it or not. When they're well and talking and conscious and, then we have to read all this stuff, that's when it gets complicated. When they come in, they don't get their A or their B or their C, it's easy. That's just straight away, just bang, 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 bang. So we're going to base it on priorities. What else are we going to base it on? How do you know someone comes in and they've got a wheeze, they've got a history of asthma or COPD? What tells us how we're going to treat them. So there's two essentially sort of documents that you use here. Can't remember the name of the first one, but it's got a P. It's 4 letters. PPHN primary. Is it?
Oh yeah.
Yep. What is it? The primary health.
Yeah, we have a framework, primary health. We have an urgent care framework which we
Yep.
use. Yeah.
And so that's based on that manual that
Yeah.
primary-
Yeah. The PCCM.
Yeah,
Yeah.
PP,
Primary clinical care manual.
primary clinical care manual. All right.
Yeah.
So we've got the PCCN.
That's right.
So that's going to tell us potentially how we're going to assess and treat this patient. And what else? What if we want to give medications? How do we know what medications we can give and
We
what
have
we can't give without knowing?
medication policy and standing orders. So
Yep, so you've got your standing orders and you've got your nurse-initiated medications, which confuse me because they're two different documents. So you've obviously got the whole list of medications that you can give without doctor consult. So they're basically, specifically medications. So, you can give, I don't know what they are off the top of my head, but you don't have to ring the doctor if you want to give the patient ondansetron for nausea and vomiting or whatever. I don't know if that's the case, but that's an example. And your standing orders more relate to patient presentation. So there is one on asthma, I think, that says if a patient presents with this, then give salbutamol, give Atrovent or ipratropium bromide, and then this, then call the doctor. Yep. So you've essentially got 3 main things to refer to. Because we know that we can't just go in and, all right, this patient can't breathe properly, let's perform an emergency tracheotomy and see if that works. We know we can't do that because we're going to follow these 3 things: our standing orders, our nurse-initiated medications, and our PCCN. Does everyone know where the PCCN is located?
PCCM.
M.
Yeah.
M.
It's in urgent care.
Yep. So there's a book form. It's above the. You've got a computer there, haven't you?
Yeah.
Yeah, it's sitting above the computer, and it's also on the computer. Is that correct?
Yeah, that's
because
right.
it's updated.
The
Yeah.
clinical links.
So those are the things that are going to tell you what you need to do, and it's okay to refer to them if you're not 100% sure, because you're going to get the presentations that aren't sort of common things. Present time to time. When was the last time you saw a group present to urgent care? Probably not for a while. So that might be something you need to refer to those things for. And so what I'd suggest is, when we go into sort of different sort of environmental seasons, is to sort of have a bit more of a closer look prior to these things happening. So we're going into hot weather, so we want to look at heat emergencies, we want to look at drownings or partial, near drownings. We'll look at some traumatic injuries because no doubt we might get them happen. We're going into harvest, which means grass fires, so we might get some burns. Whereas when we're going into winter, we focus on our asthma and our bronchiolitis and all that sort of stuff as well. So that's our plan. What are we going to do next? We've come up with the plan.
Treat.
Then we're going to treat. Yep. So we're going to treat the patient pretty much based on what they say and our level of training and all that sort of stuff. We're going to treat, and then that takes us back into anyone? Reassess. So we've essentially got our pretty much our circle of life, we'll call it, because this is what is actually going to sustain life and prevent the patient from, or reduce the likelihood of our patient deteriorating whilst they're in our care. So going back, very simple. Assess the patient. We want to know their ABCs. Do they pass it? We want to know, are they presenting with an injury? So we want to know the mechanism of injury. How did that happen? You've got no leg. How did that happen? Or the nature of illness. Okay, you've got chest pain, or you've got breathing problems, or altered conscious state, or whatever. We're going to assess their background, medications, past medical history, allergies, social status. Going to look at their vital signs, GCS. We want it to be around 15, BSL 4 to 8, BP systolic 100 to 140, HR heart rate 60 to 100, SpO2 anywhere above 93 is good. ECG, we want a normal sinus rhythm. respiratory rate 12 to 20, temperature 36.5, 37.5, around that sort of area. 100 k's an hour, and they're 64 years old, and no doubt there's potentially, whether you're 6 years old, 64 years old, you're still going to have at 100 k's an hour quite an issue being hit by a car. So are they well or are they unwell? So based on the actual and based on the potential. So actual and potential. And there's nothing wrong, we do it all the time, is get a helicopter for a potential job. Like we tried to do for our old mate with the hay bale that fell on him. We've done plenty of jobs that have the huge potential to be there, but have turned out to be actually okay. And that's fine, because if they were actually sick, we wanted them, somewhere big straight away. From there, we're going to go to plan. So we're going to plan how we're going to treat this patient using our PCCM, our standing orders, and nurse-initiated medications. If in doubt, what can we do at this point as well? Consult. So whether that be the doctor on call, or do you still use My Emergency Doc or something?
Yeah, it's usually Dr. Chris is available, and if not, My Emergency.
Yeah. So if the patient is well and we've got the ability to treat, then we probably don't need to do a consult at this point, because it's 2 a.m, the patient's presenting with asthma, their vital signs are good, but we know from our standing orders and our nurse-initiated medications and our PCCM that they need some salbutamol nebulized, some ibuprofen bromide nebulized, maybe some dexamethasone or whatever you use, hydrocort. So we've planned what we're going to do, and we can do them without authorization. So we're going to start to treat, and then we're going to reassess. How often do we need to reassess?
Whenever we find there's a change in.
Yeah, so it will depend on what's actually presented to you. If you've got an unwell patient, you want to be doing it every 5 minutes. If you've got a stable patient, 15 minutes. If you're holding on to a patient for some, whether it be waiting tests or something like that, then, whatever that may be based on your, protocols and things like that. And especially if they're doing, you've got patients in overnight or in the acute ward or something, you might not be doing, you might be 8-hourly obs or something like that. It will all depend on the situation, but if you've got someone sick, you want every 5 minutes. And it's just that idea of just remembering this circle, circle, circle. It's a continuous circle. We don't just get to this point and then we're done and then we're all good. We keep going. So, because there's nothing saying in 5 minutes time, when we've reassessed this asthmatic patient, that they're now unwell. They were fine before, so we didn't call the doctor because they presented well, we treated them, and then we reassessed them, and now we found that they're not unwell. Sorry, that they're not well, that they are unwell. So then that's changed. So now, all right, what's our new plan? Well, we're going to try this, and we're also going to consult, whether that be doctor, My Emergency Doc, or ambulance 000, whatever.
We have right pens as well.
Yes, yep.
Which is another thing
Yep. So the right burn manual as well.
Yeah, Ripen use the same PCCM, but they have some drug therapy protocol which they can administer without doctors. We have a BDH collaborating model of care.
Yep.
If it's triage less than 3, we don't have to call the doctor in after hours. So
Yep.
Ripen can manage, if manageable, if have confidence and management.
Yep, no, that's good. And look, if in doubt, just call early, because some of these things you're not going to see all the time, and
That's right.
God help me if I go to an imminent delivery, I'm not going to know what to do. I've always been lucky to miss them. In my 8 years in ambulance, I've always missed a childbirth. I've either got there just after it happened or got to the hospital just before it happened. So should it actually happen, it's complicated. Because they when you call for something like that, they keep you on the phone and the call taker guides you what to do. I always have this picture in my mind that I'm going to rock up by myself to an imminent delivery childbirth, and the ambulance call taker is going to try to hang up, and I'm going to be like, no, tell me what to do now. So, don't be afraid to consult early, and, with the ambulance, if you call it a 000 for an ambulance and the ambulance gets sent, then the clinician, which is an intensive care paramedic at Ballarat, will pick up on the job, because anything that's time critical that comes out of a medical centre will get flagged. So then the clinician will probably ring you and say, what do you got, that sort of thing, and he may even give you instructions if you can't get a doctor or whoever. So, or he might be ringing us, he or she might be ringing and ask questions to say, sounds pretty sick, we're going to start sending a helicopter your way as well, which has happened. So we've had a couple of STEMIs that we've flown out of here with a helicopter. So, any questions?
So in aged care we use this, we have PCs and ENs, and they use that tool as well.
Yep.
So for to identify any deterioration, so that's called a stop and watch tool.
Okay.
So
Yep.
are you familiar with that? That's
No,
it's
it's the
only
first
in
I've
aged
seen of
care,
that. Yeah.
So
And
so,
yeah, and look, that's important because it sort of bases on people, aged care that you're not going to be assessing every 8 hours or every 15 minutes or whatever. So to when are they at the point where they noticeable change that actually may need intervention. So I've never seen that before. So
that's it seems because we see our residents every day and we find these changes and then we report to the RN to initiate, so to identify and act accordingly at the earliest. So it seems different than usual, talks or communicate less than usual, any of the residents, and the oral need more help, like we need to give more help than we used to give, and participate in activities less than usual, not interested, and eating less and drinking less. And there is a weight change we notice. We weigh every weekly. If there is any significant weight change, more than a kilo, in a week, or 3 kilos in 3 months, so that's a significant change. And if it's more agitated, there might be a background UTI or another acute delirium. We have a delirium screen which the RNs initiate if they report it. And if they're increasingly tired, it can be as simple as a sign of dehydration, or it can be something critical as well. And change in the skin color or a condition, and more needed help with the walking. So this tool is available throughout, in handover room if you want to. So these are signs, especially with one of our resident had a clinical deterioration, and everyone noticed it, but no one, initiated the protocol. So these kind of, things might help as well. Sorry to interrupt, Joshua.
No, you're all good.
I thought I'll just add it to.
Yeah, absolutely.
Yeah.
No, I'm done. I'm pretty much done. So, has anyone got any questions or happy with that? Not too. I mean, it looks confusing. It looks like what's that movie? The someone that writes all over the windows. But hopefully that was helpful, and it's just about that. Recognise the importance of that reassessment, and that you may have to follow. Start at the start, go back. And if you're with a sick patient and you just, where am I don't really know where I'm up to, just start at the start. DRS, ABCD, literally the primary survey, DRS, ABCD. Let's go back through. ABCs, are we good? Yeah, because the ABCs are what's going to kill someone. So anything that ever kills someone will be their airway, their breathing, or their circulation. It's the only 3 things that will kill someone. So if we can tick all the boxes with all them, we're going to sustain life as long as we can, essentially. The rest is just good to know.
Excellent.
Cool. All right. Thank you very much.
Thanks, Josh.
Thank you.